Good evening, everyone, or good morning if you happen to be on the other side of the GMT line. Welcome to the second multimodality rounds of the Imaging Working Group of Emirates Cardiac Society. My name is Faraz Al-Badarin, the head of the Imaging Working Group, and I'm very excited about this session. We have a panel of astute clinicians and skilled imagers who will tackle a very relevant clinical topic. It's also my pleasure to welcome a close colleague and my co-moderator, Dr. Paul Kremer from the Cleveland Clinic in Ohio. Dr. Paul Kremer is a true multimodality imager with extensive experience in radionuclide imaging. Paul?
Excellent. Thank you, Faraz, for that kind introduction, and it's a pleasure to be a part of this symposium. As you said, these are clinical questions that arise for us every day, and I think what we'll see in this discussion is that these decisions are often nuanced and really depend upon specific patient characteristics and the integration of our imaging. So I'm very much looking forward to the session today. Thank you again.
Thank you. We're very delighted to have you. Today, we're going to discuss optimizing coronary vascularization decisions in patients with ischemic cardiomyopathy, a very clinically relevant topic. And without further ado, I'm going to introduce my close friend, Dr. Fahad Al-Sindi, who is a heart failure physician here in Cleveland Clinic, Abu Dhabi. And we will be laying the foundation for this session by discussing the role of medical therapy in patients with ischemic cardiomyopathy. Dr. Fahad, the floor is yours.
Thank you very much. Thank you, Dr. Faraz. Thank you, Dr. Kramer. Appreciate this kind invitation to this extraordinary meeting and very challenging and very topical topic. Just going to share my screen there. Okay. And do you see that? Is that clear? All right. So I have no relevant disclosures. And when I kind of thought about medical treatment for ischemic cardiomyopathy, I wanted to see what I'm up against, and to do kind of a quick used to be literature search, but now Google search to see what are the level of randomized data that are available to answer this very important question of management of ischemic cardiomyopathy. And I found one randomized trial, and I found another trial that had a 10-year follow-up. So I knew that my task, ever so much might look easy or look difficult. I also found another 3 randomized trials looking at, CABG revascularization versus medical therapy, but as it happened to be, it excluded heart failure patients. Not surprising. Now, just to kind of lay the land for this very exciting symposium, to start with the clinical case, a 71-year-old patient with severe protracted dyspnea on exertion, leg swelling and orthopnea, significant heart failure presentation, diabetic hypertension, chronic kidney insufficiency, with a creatinine of 2.9. He's on all the relevant medications for his comorbidities. Obviously presented with acute decompensated heart failure. I apologize. So the electrocardiogram showed the QS pattern, consistent of a previous anterior infarct. As you can see, the patient presented with a significant decompensation. The pro-BNP was around 35,000. So, for the group, what's the likely cause of this patient's cardiomyopathy? Is it uremic cardiomyopathy, ischemic heart disease, hypertensive heart disease, and diabetic cardiomyopathy? And kind of for briefness and for the sake of the presentation, the thought is that this is ischemic heart disease, ischemically driven, and that's not surprising because of the commonality of acute and chronic heart failure that has increased the cost as well as hospitalization. Not only that, but significant coronary disease constitutes around 50 to 60% of our patients with congestive cardiac failure. And you can see data actually as far as the Solvid registry, looking at around 6,000 patients, saying that the majority of those presenting with heart failure are ischemically driven. This is another pooled data of around 43,000 patients looking at the incidence of heart failure, and the great majority actually had decompensated heart failure. When we look at de novo heart failure, coronary artery disease as a cause of incidence in population, we also see that coronary disease constitute more than 50% of this population. Now, this does not come, with a price tag to it. So as these patients present, they're more likely to have significant coronary occlusions. And not only that, they're also tied with significant mortality independent of the next coming 5 years. Ischemic etiologies have shown a worse prognosis over time compared to the non-ischemic and to the other types of cardiomyopathies. And not only that, the long-term prognosis has been tied actually to the number or degree of lesions with coronary disease. So the more complex the patient is, the more likely that they're not going to do well over time, also indicating the need or question for revascularization. Now, chronic heart failure, this is data from the Atlas trial showing that a lot of those patients actually die, and they die actually at the time where they are more vulnerable, meaning they might be walking and talking in a class 2 configuration where they confer the highest level of mortality. As we all know, as cardiologists working in the CCU, we know those patients who come in with acute decompensated heart failure can present very in a dire situation, and we can see that the highest mortality is in cardiogenic shock. And this is a study looking at Philip class, as a function of prognosis and presentation over 10 years. And you can see the worse the presentation, the worse. And I put this as just as the group starts to discussing ischemic revascularization, is a patient who presents with acute decompensated heart failure, Philip class 3. Really medical therapy becomes a very difficult option because that patient might and will come back again. Now, just to continue with our patient, the patient had an echocardiogram, not surprisingly, severe LV dysfunction. The inferior wall is slightly moving, but the anterior septal wall is down. This is a short axis view showing, acute decompensated heart failure and acute LV dysfunction. So the next question to the group, which of the following describes his cardiomyopathy presentation? And we sometimes talk about these types of transient cardiomyopathies. And, hibernation, stunning are all words that we kind of, fathom during the acute phase. Just want to kind of, talk a little about stunning. It's prolonged reversible post-ischemic contractile dysfunction. And mostly it's the loss of sensitivity to the calcium filaments and for contractility. Most important that it's a complex interplay of multiple factors. And as you can see in yellow here, one of them is microvascular dysfunction and coronary perfusion, but there are other microvascular and biochemical abnormalities that also occur. And we can see from experimental models that stunned myocardium does recover, and the apoptotic phase of death can be circumvented by revascularization. This is an acute stunning phase. But as you can see with myocardial hibernation, that's a different, more difficult question. It's a more insidious onset that actually kind of, can baffle a lot of us cardiologists. And it's usually an adaptive response to chronic ischemia, but I'd like to call it a maladaptive response to chronic ischemia because LV remodeling ensues, hibernation might kind of trick a lot of us clinicians, saying that this is an end-stage process and it's unlikely to reverse. It's important to also think about that hibernation is a self-protective mechanism. You're trying to kind of reduce the energy expenditure. You start to reduce your ATP expenditure. And it's important to note that there is a staged process of hibernation. And we always have this discussion about, do you think this is viable? This is non-viable. I promised my chairman that I'm not going to go into the details. I'm just going to kind of give a summary. But these are things that we really want to think about as we go to this presentation. Now, when we talk about next step in management of this patient, would we just medically manage? Would we cardiac cath? Would we do a CT course knowing his creatinine, or would we do an imaging stress ischemia evaluation formality? The patient underwent cardiac cath, and as you can see, severe left ventricular dysfunction, and you can see the hairline LAD, in addition to a circ lesion with some distal RCA, but there was no doubt that the LAD was the a significant culprit in this stage. As I remind you from the initial presentation, the patient's troponin was flat, it was around 0.1, so it wasn't a classical acute coronary syndrome or ST or non-ST elevation MI. So as we can see, and we will see in our presentation with our colleagues, that in this instance, we need more data to be able to actually come up with the best way to tackle this patient's presentation. And there's no place better than the heart team approach. With all humility, we actually meet on a daily basis cardiologists, advanced cardiac imagers, as our colleagues here, interventional cardiologists, heart failure specialists, EP, the whole team, cardiac surgeons and cardiac anesthesia, to discuss this. But beware the Ides of March sometimes, because if you're bringing up a case with your colleagues, you don't know the actual response, and you have to really have good friends in the Senate and good friends in the heart team to try to kind of sway decisions sometimes. But needless to say, medical therapy, CABG, and PCI or viability are the four things that we actually talk about. And just to kind of one or two slides about viability, definition of viable myocardium. But more important, as my colleagues are going to discuss further, there are different modalities of viability. Some of them have undergone the test of time, and some of them, as a matter of fact, has reached in new stages, such as Cardic Mri and FDG PET and perfusion imaging. Now, dead or alive is a question that I think about when I look at an echo, when I look at a patient, when I look at an ECG. And there's no doubt in our mind that when we think about meta-analyses, looking at viability, and this is a study looking at around 24 studies, that if the patient is deemed to be viable, then whether you take the revascularization route or the medical route, patients do better when we perceive them as being viable. And without going into the details, I'm sure this trial is going to be talked about in detail, but thinking about the STITCH trial and how it compared, medical therapy with CABG, albeit in the initial STITCH trial, there was some challenges with statistical relevance. But it's important to note that whether you were, when you were viable, whether you went the medical or the CABG route, patients actually did better. Now, again, I'm not going to prolong this, but important to know our sample population who was actually studied in the STITCH trial. And as you can see that this patient who came in with acute decompensated heart failure, also to note that viability was under the duress of our physician. It was most patients I'm going to send for viability. Now, is CABG safe? And we have this discussion always, and I'm not going to go into the detail, but CABG is quite safe. There are things that make CABG more challenging, comorbidities, age, but you can see from this cohort, the 17-year follow-up, that the 14-day mortality still remains within very good mortality percentages. And as you can see, the more complex the patient gets, the more higher the mortality. Now, I'm not going to go into the details of revascularization or PCI, but the Syntax investigators, the Freedom trial, and even with diabetics are hopefully going to be looked at. Now, we promised guidelines, and I take you back in time in 2013 and see that CABG or PCI with heart failure with preserved or reduced with guideline-directed therapy with a left main greater than 50 is a class 1 recommendation. And at that time, when you have mild to moderate LV dysfunction, is a class 2A. But going to the 2014 guidelines, again, it was a class 1B recommendation for left main stenosis or significant 2-vessel, 3-vessel disease with angina, with symptoms. And when we look at the European 2018 guidelines, the recommendation of vasculation patients with chronic heart failure with an ejection fraction of less than 35%, and in patients with LV dysfunction, suitable with myocardial revascularization is a class 1, and CABG is recommended as the first stage in patients with multi-vessel disease, which is acceptable. Now, there's some class 2As as we see them there, especially when there is 1 or 2 vessels involved. And finally, I am just going to touch on the STITCHES trial, because this is the 10-year follow-up that actually was statistically significant and showed, favorability of the revascularization, as we extended the time period between medical therapy and CABG with a significant 16% reduction, and a number needed to treat of around 14 patients to save one life. Again, stitches, still the jury is not completely out, as far as, final decision making. But I just want to take you back to the patient. So the patient underwent PCI to the LAD, and they opened up the vessel much beautifully from our interventional colleagues. And the patient only had a single PCI. And I put this case, real case, just to kind of show that after 6 months, the patient left ventricular ejection fraction significantly improved and quite normalized compared to when the patient come in. Again, indicating that despite our guidelines and our evidence, we are still lacking to understand why certain patients improve, such as this patient. And needless to say, he remained in class 2 heart failure. His creatinine improved to around 1.3, and he did well thereafter. Now, this is my kind of summary slide of all the trials that we have. And as you can see, ladies and gentlemen, most of them were observation, and there was only 1 or 2 that were randomized plus observation. Now, I am towards the end of my presentation, and I want to talk about enrolling patients who have ischemic cardiomyopathy and heart failure in a randomized fashion. Until now, we do not have a trial. We have this UK-based trial that actually looked at hospitalization due to heart failure and revascularization, enrolling patients with poor EF, but it took a very long time to enroll. And as you can see, this is my slide in 2018, enrolling 400 patients, but the recruitment and follow-up is complete for those patients. And the randomization of these patients are for viability as a modality following enrollment, and then deciding whether the patient has around more than 4 segments of viability, and then to randomize them to optimum medical therapy and PCI for primary endpoint of all-cause mortality and hospitalization. And this is going to be a very, very interesting and yet pivotal trial in our understanding of ischemic cardiomyopathy. And with that, ladies and gentlemen, Mr. Chairman, I want to finish by saying that ischemic cardiomyopathy is a complex cardiology and medical question. I think viability, as we're going to learn, has many modalities and many roles used in the good clinical situation. The heart team approach remains pivotal in our understanding and collegiality, being able to take this complex medical decision. And revascularization, I believe, has an important role, especially if the risk of mortality or morbidity is low. And we are hopefully waiting for more evidence and waiting to this fantastic symposium. And with that, I thank you very much.
Excellent. Thank you, Dr. Al-Sindi, for a very comprehensive overview of really putting the guidelines and the evidence in the context of a clinical case. And so now it's my privilege to introduce our next speaker, Dr. Yusuf Al-Attar. He's a consultant cardiologist and multimodality cardiovascular imager at the Sheikh Shabood Medical City in Abu Dhabi. And he will be discussing the role of echocardiography and MR-based assessment of myocardial viability.
Good evening, everyone. This is Dr. Yusuf Al-Attar. I am a cardiologist with a special interest in cardiac MRI and cardiac CT, and I've been tasked to talk about myocardial viability and how to assess it with the stress echo and MRI. I apologize for not being able with you live, as at the time of this presentation, I should be on a flight back to Abu Dhabi. So in the 70s and 80s, physicians have noticed that the dysfunctional myocardium patients with coronary artery disease have often improved post or completely reversed post-CABG. The definition of viable myocardium is it's a dysfunctional myocardium with limited or no scarring resulting from coronary artery disease and has the potential to improve once blood flow has been restored. And there are 2 types. There is the myocardial stunning and the myocardial hibernation. What we need to know about ischemia is that in severe ischemia, the anaerobic metabolism starts within seconds. The contractile dysfunction happens as early as 2 minutes, and the necrosis can occur from 4 hours with a complete infarction that can happen any time from 6 hours. If reperfusion occurs within 20 minutes, the structural defects are usually entirely reversible. Why are we talking about myocardial viability? The CAST registry, coronary artery surgery study registry showed that in patients with an ejection fraction of less than 35%, it is a long-term survival study. So the 5-year survival in CABG patients were significantly better than those with medical management. And the difference is even more prominent when the ejection fraction is less than 26%. This is a meta-analysis that was also published 20 years ago that shows that in a viable myocardium, the death rate in revascularized patients is way better than those with who were treated medically, whereas with non-viable myocardium, there is no benefit. This is another paper published in 2011 that shows that the 3-year survival was significantly worse in medically treated patients with viable than with non-viable myocardium. So it is important to study viability to direct our management. So the first phenomenon is the myocardial stunning, and it is defined as a prolonged and reversible dysfunction of ischemic myocardium, despite the absence of irreversible damage and despite the restoration of normal blood flow. So there is a brief interruption of coronary blood flow that has a lasting effect on the contraction. And here we are talking about from hours to 6 weeks of this myocardial dysfunction post-insult, depending on the severity and the duration of ischemia. It was first described in 1975 on dog studies, where they introduced this 5-minute ischemia, and the myocardial dysfunction lasted for 6 hours, and in another dog they introduced a 15-minute ischemia, where the myocardial dysfunction lasted for more than 24 hours. Why it happens? It's still under investigation. The oxygen-free radical hypothesis has compelling evidence behind it, and the presence of these oxyradicals have been proven by spin trapping techniques and stunned myocardium. Calcium overload hypothesis have been proven in vitro, but the importance in vivo is still under investigation. Excitation, contraction, coupling this, the inadequate release of calcium from the sarcoplasmic reticulum can cause this effect. So the stunning is usually fully reversible. The function is fully reversible if ischemia lasts less than 20 minutes. It can be only partly reversible if ischemia is more than 20 minutes, but less than 3 hours. We see it post-ROSC, we see it post-exercise-induced ischemia, and we can see it with coronary spasm, and has good response to inotropic support. We're going to talk about this later. The hibernation, on the other hand, is an adaptive reduction of myocardial systolic function in response to reduction of myocardial blood flow. So there should be a longer period of ischemia or of reduced coronary blood flow, and the heart adapts and reduces its ejection fraction or systolic function, and hence the metabolism. It's also described in the 70s, also in dog studies. And Rahimtullah has an important paper in the 80s. I encourage everyone to read about it. So why it happens? Smart heart hypothesis. The heart knows that there is a reduced coronary blood flow, so it reduces metabolism. Repetitive stunning, so stunning after stunning after stunning, and the heart also recognizes this and reduces the contraction. And the survival hypothesis goes hand in hand. So there has been proven that there is upregulation of survival genes in a hibernating myocardium. Probably it's all of those things happening together. There's severe ischemia, repetitive ischemia, and the decrease of coronary perfusion pressure and post-stenotic coronary beds, and of course the gene expression. We estimate that 20 to 50% of patients with chronic ischemic LV dysfunction have considerable areas of viable hibernating myocardium that can improve post-revascularization. I'm showing this to show the ischemia cascade before talking about the modality. So the perfusion abnormalities usually are the first things that get affected, the perfusion itself. This is before the diastolic and systolic dysfunction, before any ECG changes or symptoms. That's why perfusion tests detect the disease earlier in the process. So adenosine, SPECT, PET, and perfusion stress MRI can detect the disease and the hypoperfusion time. where the dobutamine stress MRI, exercise echo, or dobutamine echo depend on studying the contractile reserve a bit later in the process. For exercise echo, dobutamine echo, many indications, of course, for coronary to detect if there is ischemia or if the myocardium is viable, but also other indications, mitral stenosis, aortic stenosis, pulmonary hypertension, that we cannot talk about in this presentation. Dobutamine in itself is a synthetic short-acting catecholamine beta-1 receptor stimulant, so it enhances myocardial contractility, has some balanced beta-2 alpha-1 actions, so the net effect of those are negligible. There is a linear correlation between the dose and the plasma concentration. The half-life is short, should be administered by IV infusion, and it is rapidly metabolized by the liver. Like the exercise stress test has many contraindications, active infection, active inflammations, acute MI, unstable patients, aortic dissection, severe aortic stenosis, arrhythmias, some uncontrolled arrhythmias, and there are other relative contraindications. So for the dobutamine, for the dobutamine stress echo, so we start by the images at rest, and then we do the stress protocol. We start with the low dose dobutamine, so we start with 5 micro per kilo per minute, and then we increase the dose gradually every 3 minutes, and about 30 or 36% of the patients we need to use atropine to reach that targeted heart rate. And then we study the wall motion based on the 17 segments, on those 17 segments, which will hint us towards which territory or which coronary is involved in the disease, if any. And then we study the wall motion abnormalities. So normal myocardium, normal thickening in systole, hypokinetic, where there is reduced thickening in systole, akinetic myocardium, there is absence of thickening in systole, and dyskinetic, where there's paradoxical wall motion during systole. It's an echo, so we have the chance to look, and we should be looking at the LV cavity dilatation, the systolic diastolic dysfunction, and if there is a new worsening mitral regurg. So this is the table I use to interpret stress echoes on normal myocardium. At first, there is no wall motion abnormalities, and then the wall motion becomes a bit hyperdynamic with the dobutamine. And ischemic, at first, there's no wall motion abnormalities that appears later on with the dobutamine. A scarred myocardium, usually akinetic or dyskinetic, that is not responsive to dobutamine. And stunned myocardium, there is wall motion abnormalities that improves with dobutamine. It has good response to it. And in hibernating myocardium, there is this biphasic response. It's simply because the heart cannot cope with the increasing demand. And if you see this, this is a good sign and good indicator that the myocardial function can be restored post-revascularization. Again, it's not perfect, has false positive, false negatives. That's why it's important to be done by someone who does this on a regular basis. This is an example you see here on the left upper corner, apical four-chamber view, where this is the myocardium at rest. There's no wall motion abnormalities. On the right to it, you see at peak dobutamine, where there is hypokinesia in the apex. Sometimes the acoustic window is not optimal, so this is to remind you that we can do stress echo with contrast. On the left side, it is again four-chamber, apical four-chamber with normal contraction at the apex, and to the right of it, this is with low-dose dobutamine. We see this complete akinesia of the apex. It has excellent sensitivity and specificity for coronary artery disease, as has been shown by many studies, and also for predicting the functional recovery in stunned or hibernating myocardium. So the contractile reserve, so remember there is wall motion abnormalities that improves with dobutamine. This is 90% sensitive and 65% specific, while if we use the biphasic response on hibernating myocardium is 80% specific. The advantages of echo, it is specific. You can assess the valves, the diastolic function, whether there is pericardial effusion or systolic pressure. It is cheap, available, there's no radiation and no nephrotoxic contrast. Disadvantages: the inter-observer variability, reproducibility, it has a learning curve, should be familiar with it. Acoustic window, especially in obese and COPD patients, render it sometimes difficult to interpret these studies. Now, when we talk about stress cardiac MRI, there are two techniques. There is the butamine stress MRI, which studies the contractile reserve as the echo, and there is the perfusion stress MRI, which is what most people refer to when they talk about stress cardiac MRI. So the butamine stress MRI, exactly same like the echo. It doesn't need contrast. Studies the contractile reserve, same protocol as the echo. It is more specific. It is less sensitive, but more specific, as shown in some studies than the stress perfusion techniques. It answers some of the disadvantages of the echo, like the obesity, COPD, acoustic window. But it has absolutely no effect on the quality of the images in MRI. And the inter-observer variability or reproducibility is less because it depends on the technology. But you cannot assess the historic function. I've published many published papers on how to study the historic function, but it is not standardized and needs special softwares. You cannot study with it the RV systolic pressure. It is definitely not cheap and not as readily available as the echo. Now, the stress perfusion CMR. The two most, we use vasodilator agents, and the two most used agents are adenosine and regadenoson. And regadenoson have been used more and more lately as it is easy to use. It's just a single bolus that given over 10 seconds, and that's it. Very quick in action, 70 seconds, and it is very selective to A2A receptor agonist, where it causes much less bronchospasm than adenosine. And when we do perfusion stress MRI, we study two things. We study the perfusion itself, and we study the delayed enhancement, and both are excellent for diagnosing coronary artery disease and to study viability. So we do the perfusion first, and we compare perfusion at rest and on stress, and then we study the delayed enhancement. So the gadolinium itself, through what it does, it produces the T1 of the tissues, but in healthy cells that has intact selectively permeable cell membranes should be excluded from the cells and restricted to the interstitial space. If you see here, so there are two phases. So the first phase where we study the first pass, you see that there is a difference between the green line and the white line. The white line is the ischemic and the green line is the normal myocardium, and this difference can be detected, as I'm going to show you in an example now. And then 10 minutes later, there's no difference between normal myocardium and ischemic myocardium if it is viable, but the infarcted myocardium, because the gadolinium particles are trapped and cannot be easily gone or excluded from the area, it has this signal that you see it as white signal. So this is a case to show it. An old man with previous coronary artery disease has some ischemia. When he came to the MRI, this is his short axis cines, and we see that the ejection fraction normal. There's no wall motion abnormalities. Ejection fraction, in fact, 61%. This is the long axis for 2 and 3 chambers. And this is the perfusion that we did with Rapiscan. You see here in the septum and the basal and mid septum, there is this perfusion defect. And when we study the late GAD 10 minutes later, you see that there is no late GAD enhancement. And this is a positive test for ischemia. Advantages of the MRI, it has good, excellent resolution, 1 to 3 millimeters. It is simple to use. Gadolinium, the contrast that we use is a small amount of contrast that is used. And it is a comprehensive study, and you can study the viability with stress or without stress, or even with only late GAD enhancement. This is the table I use. Again, we study the cines images, as I shown you. We study the perfusion at rest and stress and compare them, and then we study the late GAD imaging. So normal myocardium, everything is normal. And ischemic myocardium, the wall motion is normal. There's no perfusion at rest, but appears on stress and has no late GAD. In a stunned myocardium, there is hypokinesia with normal perfusion at rest, but defect on stress, and again, no fibrosis. Hibernating, there is one-wash abnormalities with defect at rest, and the stress it mimics sometimes the infarction, but it has absolutely no late GAD imaging. And then infarction, you have this fibrosis on late GAD. Many studies have shown how do we study and how much, how do we interpret the late GAD images, and most of them agree that if the from the transmurality, if the late GAD is 50% or less, we consider this as viable myocardium. Above 75 is non-viable, and in between it depends, but it leans more towards non-viable than viable. We take other things in consideration. Many studies have shown the effectiveness of this, and the sensitivity and specificity are excellent in meta-analysis and Lancet papers. And Kitagawa at the end there, you see that post-revascularization functional recovery, the late GAD is 98% sensitive. Before I finish, I'm going to leave you with this study. You're going to hear a lot about it. This is published less than a month ago, the Revive2 study, that studied patients with an ejection fraction of less than 35% with viable myocardium, and then they've been randomized to PCI and optimal medical therapy. So 700 patients randomized, and then there was absolutely no difference in death and no difference in hospitalization for heart failure. Just want to make a few comments on this study. So older people, 70, the average age was 70, without angina, and if the patient needed device therapy, it was given. So there are ICDs on both sides. ICDs appropriately shocked optimal medical therapy group and 13 incidents, but only 6 in PCI. And we see this probably because the optimal medical therapy nowadays is excellent, and it will be interesting to see what how this study will affect the practice in our hospitals, and we'll have to wait and see if there are more studies that will come in the favor of Revive2. So this is my talk. I'm going to leave you with these 2 slides. This is how we interpret the stress MRI and stress echo. If anyone wants to take a picture of this, please do so. I find them very useful. Thank you very much for your time, and I hope next time I can be with you in person. Take care.
Thank you so much, Dr. Youssef. I know you were not live with us, but that was an excellent overview of both echo and CMR. There was mention of another modality that can be used to assess myocardial viability and hibernation, which is radionuclide imaging. And no one is better to discuss the role of this modality in ischemic cardiomyopathy than Dr. Paul Kremer. Dr. Kremer, the floor is yours.
Excellent. Thank you, Dr. Faraz. And as you noted, I'll be discussing viability assessment using radionuclide imaging. But before I start this talk, any viability talk, and I think we'll touch upon this in the other discussions as well, is really the first question is, does my patient actually need viability testing? And we know that in the extension study of Stitch, if you follow patients long enough, there was a benefit from CABG. So I would just preface this by saying that in the patient with coronary disease and reduced left ventricular systolic function, not all of the patients need viability testing. And when we look at viability testing, what we're assessing for is recovery of function. That is really the gold standard assessment, but it's worth noting that this is a surrogate imaging endpoint. And of course, what we really care about is what happens to patients, in particular in terms of worsening of heart failure hospitalizations, and all-cause mortality. And there's other things besides viability testing that can factor into prognosis of our patients, the extent of the coronary disease, how severely embarrassed the left ventricular systolic function is, and how dilated the ventricle may be. And all of these factors are considered in our imaging assessment along with the viability testing. So with that, by way of preface, what I'd like to focus on in my talk is first describe how we acquire and perform PET myocardial perfusion imaging, and then discuss the role of F18 FDG in evaluating these patients, and then touch upon the interpretation of these studies, and then briefly conclude with some data related to PET viability and revascularization outcomes. So I'll be focusing on PET for viability assessment, which is primarily what we use, or is exclusively what we use in terms of radionuclide imaging. And I'd say at our center, it's mostly PET for viability or cardiac MRI. And there's some reasons why PET is superior to SPECT. For one, we're acquiring images at peak stress in the assessment of ischemia. PET has improved spatial and temporal resolution. Importantly, which I'll touch upon, is with PET, we can quantify absolute myocardial blood flow, and that can be important in terms of prognosis and downstream decision-making. And in PET, the radionuclide tracers that we use have shorter half-lives, which does lower the effective radiation dose compared to SPECT. Now, there are some disadvantages because of the short half-life of the radiotracers. At least currently, exercise stress protocols are challenging, and that, as we know, can be important in the assessment of our symptomatic patients. So these studies are done with vasodilators, and it does require either an on-site cyclotron or relatively expensive generators. So similar to SPECT, the images should be oriented manually or automatically in a standard way. So here you can see the vertical long axis, like our two-chamber view with the anterior and inferior walls, and the horizontal long axis with the septum and lateral walls. And so this is standard across SPECT and PET modalities. And then other things to think about for quality control. So we look at the CT transmission scan for any artifacts. We always want to make sure that our count statistics on our emission images are adequate. And we want our alignment between the transmission and emission scans to be precise in axial, sagittal, and coronal planes. And we should always, in nuclear imaging, look for motion artifact. With PET, it is difficult to assess for motion artifact because we don't have the rotating tomographic images the way we do with SPECT. And the primary way we look for motion artifact in PET is by looking at the dynamic data acquisition on a cine loop. So we, of course, look at the gated images at rest and stressed. So this is just an example of a normal stress rest rubidium PET. Our interpretation is the same as what has been highlighted using the 17-segment model. And we want to describe the extent of the defect according to these segments and the severity of the defect from mild, moderate to severe to absent perfusion. And we use these scores to create some stress, some rest, and some different scores. Importantly, we also look at the CT for attenuation correction to look at the extent of coronary calcification and any relevant non-cardiac pathology as well. Okay, so to move on to metabolism imaging. So FDG is the only FDA-approved technique for myocardial viability. And the way this works is that the F18 labeled glucose competes for transport and phosphorylation with normal glucose circulating in the body. And I think an important concept to emphasize is that in the normal condition, normal myocardium preferentially uses free fatty acids for metabolism. And there's really states of injury, which we'll touch upon, where the myocytes shift to using glucose. And it's this shift from using free fatty acids or ketone bodies to using glucose, which is the foundation of viability imaging with FDG. So what happens in the setting of either ischemia, hypoxia, is that the proportion of GLUT4 transporters at the plasma membrane increases, so that there's preferential use of glucose in ischemic myocardium compared to normal or non-ischemic myocardium. And this has been touched upon in the previous two talks, so I won't belabor it, but it's an important concept, the difference between stunned myocardium, where there is a regional wall motion abnormality during an ischemic episode, that ischemia is relieved, and then there is a return to normal function, in contrast to hibernating myocardium, where there can be repetitive ischemia and chronic hypoperfusion, often not in the context of an acute injury, and with restoration of blood flow, there's also a gradual return to normal function. So when do we use FDG PET for viability assessment? So when we're trying to evaluate for hibernating myocardium, so that's dysfunctional myocardium that has the potential to improve with revascularization. Often that myocardium will improve with inotropic support. It has maintained its cell membrane integrity, is using glucose as a substrate, and has a histology that correlates with live cells. So the major question we have is the reduction of myocardial blood flow at rest due to scarred, non-viable myocardium or hibernating myocardium? And this has important clinical applications because we generally think that hibernating myocardium will benefit from revascularization in terms of recovery of function, whereas scarred myocardium will not. Another important point is when do we not perform a viability assessment with cardiac PET? So if a patient has a normal left ventricular ejection fraction, the vast majority of the myocardium is viable, so you don't need a viability assessment. I think importantly, in the patient with systolic heart failure, as was highlighted in the initial case, the first question that comes up is, are there targets for revascularization? So we only want to perform viability testing if the anatomy is amenable to revascularization. And of course, we don't want to perform testing in patients with normal coronary arteries, or if patients have had prior testing that shows no viability. The other thing that comes up a lot clinically is if the perfusion is normal at rest, even in the setting of left ventricular systolic dysfunction, normal perfusion equals viable myocardium. So what we do in our lab, for example, is if a patient comes for a rest stress, if a patient comes for a rest stress FDG study, if the resting perfusion is normal, then we'll actually cancel the FDG viability assessment because the resting perfusion is normal, so we know all the myocardium is viable. So here's an example of that. This is stress on the top, rest on the bottom, short axis, horizontal long axis, and vertical long axis slices. And what you can see on these stress images here is this perfusion defect throughout the inferior wall, extending into the inferior septum. You can see it here on the vertical long axis as well. So this is an example of RCA ischemia, and the resting perfusion is all normal. So clearly there's no need for FDG in this patient. Now, there's different approaches, though they're fairly standardized in terms of patient preparation, which involves fasting the patient prior to a viability test, measuring the blood glucose, and then if needed, administering insulin to the patient to really drive that FDG into the myocytes to try and demonstrate myocardial viability. This is the protocol we use here at the Cleveland Clinic. And we have a different approach in a diabetic patient versus a non-diabetic patient, which mainly relates to a different dosing of the insulin that's given as part of the protocol. But again, the patient is fasting, we measure the glucose, and based on those results, we either give more glucose, remeasure the blood glucose, and then give insulin, and then image the patient 60 minutes after injection of the FDG. So as I touched upon, the main thing we want to try and distinguish is hibernation versus scar. So here on this polar map, you can see this defect in the lateral, infralateral, and inferior wall, whereas there is on the FDG images here, where it's orange, it's taking up the tracer. So this is an example of hibernating myocardium where there's a mismatch defect. In contrast, on this patient below on the FDG images, you don't see any uptake of the tracer, so that's a match defect and indicative of scar. So I'm going to show just a few examples of how we use this imaging. So again, this is rest on the top and FDG on the bottom on a short axis, horizontal long axis, and vertical long axis slices. So here, looking at the resting images, you can see severe perfusion defect throughout the apex, extending into the anterior wall, and also involving the septum, where there's really absent perfusion. Now, if you look at the FDG images below, you can see that area that has the defect, it has a lot of FDG uptake in the apex, anterior septum, and the anterior wall here, as you can see on the vertical long axis. So this is an example of a large area of hibernating myocardium in the LAD distribution. Here's another example where you can see a perfusion defect throughout the inferior wall here on the short axis slice and corresponding vertical long axis slice. And then on the FDG images below, you can see that area that has the defect is very intense with FDG uptake. So this is mismatch in an area of hibernation in an RCA distribution. And finally, here's a resting perfusion defect that you can see in the lateral wall, throughout the lateral wall, extending infralaterally. And that area is FDG avid on the images below, indicative of a large area of hibernating myocardium and a circumflex distribution. So 3 examples of mismatch in hibernating myocardium. So I'll conclude just with a couple minutes on some of the data around viability assessment, especially with PET. But first, when we think about it, the sensitivity and specificity of the different modalities, what I would say in general is that FDG PET is extremely sensitive, and probably more sensitive than, say, looking at dobutamine echo, which tends to be more specific. And the reason that is because with FDG, we're really just assessing for whether the myocytes are intact and alive and using glucose. Whereas with dobutamine echo, as was touched upon, we're really looking at contractile reserve and restoration of some wall motion with administration of dobutamine. So for that reason, we tend to think of FDG PET as being more sensitive, but perhaps not as specific as some of the other modalities. And I think has also been touched upon in the previous talks is if you look at patients who in an observational study, this is 10 studies of 1,000 patients with FDG PET, those with viable myocardium tend to have lower mortality with revascularization compared to patients who do not have viability, where there's not a big difference in medical versus revascularization approaches. Now, of course, this is observational data and is subject to a lot of confounding. So what do we have in terms of the randomized controlled trials? Well, within PET, this is the PAR 2 study, which randomized 430 patients with a low EF to FDG PET or standard of care. Now, in the intention to treat analysis, the primary outcome of cardiac death, non-fatal MI or hospitalization for cardiac cause was negative. But what you'll see is this was sort of a strategy of upfront FDG PET. So of the patients who demonstrated myocardial viability, 161, a subset of those, 99 patients, went on to have revascularization. And this is a post hoc analysis, so I think we need to interpret this data extremely cautiously. But if you looked at the results of patients who had revascularization and adhered to the results that were available on the PET, there was a reduction in events. And I think what this speaks to is some of the limitations in that one, coronary angiography was not mandated prior to randomization. And it's what I touched upon earlier, is that really this evaluation starts by identifying a patient who has anatomy amenable to revascularization. And there was no assessment for ischemia. And I think we really look for the burden of ischemia to help inform the decision for revascularization in these patients with reduced EF as well clinically. So our clinical approach, as I mentioned, really begins with catheterization. And if the angiography shows that there's no targets for revascularization, that patient's going to go for medical treatment or advanced heart failure therapies, whereas we may pursue other testing to inform the decision for revascularization if the anatomy is amenable to it. So I'd just like to conclude by talking about a potential advantage of cardiac PET, which is assessing quantitative myocardial blood flow. So on the dynamic data, we can measure absolute blood flow at rest, stress, and look at that ratio. And here's an example of that, looking at these time activity curves in a patient who has normal resting, normal stress, and normal coronary flow reserves. So this is some observational data that may provide some insight in how looking at coronary flow reserve can identify patients who may benefit from revascularization. So in this observational study of 329 patients, what you can see is in the patients who had a low coronary flow reserve, they did better in an adjusted analysis if they got revascularization versus patients who had a low reserve who didn't get revascularization did worse. And it may help to decide what type of revascularization is most appropriate. So here is patients who have low coronary flow reserve on cardiac PET, and the event rates, or patients do better with CABG compared to PCI in this patient population, and sort of speaks to, I think, what has been a tenet for decades really is that in general, you get more complete revascularization with CABG compared to PCI. And here's showing that in the event rates that you can see the event rates are lowest in the patients with low CFR who undergo CABG. So to conclude, I think the take-home points are that the fundamental principle of FDG PET is that we're really imaging the shift from myocardial utilization of free fatty acids to glucose, which happens when myocardium is either ischemic or hibernating. That the viability assessment has to be pursued in patients who have established anatomic targets for revascularization. And I think it's, from the imaging perspective, it's not just about the viability, that an assessment for ischemia and in some patients, myocardial blood flow can inform our clinical decision making. So thank you again for the invitation and for your attention. And it's now my pleasure to reintroduce my co-moderator, Dr. Firas, who will be discussing coronary revascularization for ischemic cardiomyopathy in the post-stitch era to really kind of tie together what we do or how we put all this data together as clinicians. Firas.
Thank you so much, Paul. That was an excellent overview of PET and radionuclide modalities. What I'm going to try to do is to take off my imager's hat and look at this topic altogether. How do we use input from imaging to guide decision, revascularization decisions in patients with ischemic cardiomyopathy? I have no relevant financial disclosures. The idea of hibernating myocardium is not new, as has been discussed already, and it was based on 40-year-old data and 40-year-old observation, where some patients improve their LV systolic function after revascularization, predominantly CABG at that point, whereas others do not. And this brings up 2 points, is the differential response of LV systolic function to acute or chronic ischemic injuries, and that the response is different between the based on the acuity and the duration of the ischemic injury. And there is also difference in benefit from revascularization, depending on the timing of coronary vascularization in relation to the onset of ischemia. And this has driven the concept is that some myocardium is dead, whereas some other myocardium is alive and hibernating. This also has been briefly touched upon, and the hibernation is an adaptive response where there is reduction in systolic function in response to chronic reduction in myocardial blood flow. And what happens when every time the demand for blood exceeds the supply of oxygen, there is an episode of stunning, and those many episodes of stunning happening back to back on the long term result in reduction in systolic function. At the cellular level, there are several changes that are very important to mention. Number one is switching metabolism from free fatty acids to glucose, because it's a more efficient way of generating energy. And this leads to upregulation of the GLUT1 receptors. There's also upregulation of tumor necrosis factor alpha and nitric oxide synthase, which lead to reduction in systolic function. The byproducts of anaerobic metabolism lead to increase in mitochondrial permeability, and this leads to cell death and apoptosis. So you can see here as a spectrum, starting with stunning on one end and ending with infarction on the other end. And it may be easy and appealing to think that the entire myocardium is living in one of these compartments at any given point of time. However, it is probably more plausible that at any given time, there are various stages and various degrees of hibernation and infarct scar formation in any given myocardial segment. And as a result, the response to a restoration of blood supply may be different depending on which point in this cascade a myocardial cell or segment is living. This is a patient, just to show you that ischemic cardiomyopathy is not one flavor. This is a patient who presents with fluid overload, was found to have LV systolic dysfunction. He has diffusely diseased right coronary artery, a totally occluded LAD, and a small diffuse circumflex. And on his late gadolinium enhancement, there is extensive LGE in the LAD territory, manifesting as the anterior, distal septal, and apical segments. This patient outcome and management is very different from another patient who presented, who's 59-year-old with prior PCI to the LAD, presents with acute heart failure also. Again, there's LV systolic dysfunction. There's demonstration of multi-vessel disease, but this time there is the LAD territory is free of any gadolinium hyperenhancement, but most of this hyperenhancement is involving the basal, inferior, and lateral walls. These are two different patients with two different management approaches and different outcomes. So you can see how the input from echocardiography, invasive angiography, and advanced imaging need to be incorporated in decision making. So what are the objectives of coronary revascularization in heart failure? There are pathophysiological changes that you hope to achieve. First and foremost is restoration of coronary blood flow and correction of ischemia. And the idea from that is to prevent arrhythmia, ischemia-driven arrhythmia particularly, and sudden cardiac death, and also improve systolic function. There are also clinical objectives that you want to achieve. First of all, you want to help the patient. You want to improve their health status. You want to treat their angina and heart failure symptoms. You want to reduce or prevent heart failure hospitalizations. You want to prevent myocardial infarction and hopefully help them live longer. Ideally, these clinical benefits are mediated through these pathophysiological mechanisms, and these pathophysiological correction of these pathophysiological mechanisms will lead to these clinical changes. Even more appealing is to think that the relationship between ischemia, LV dysfunction, mortality is a linear and simple relationship, whereas whereby revascularization helps you reverse this cascade in the same direction. Unfortunately, it turns out that the relationship is more intricate and more complex, and even it's more complicated by lack of available data to support our understanding of the relationship between presence of viable myocardium, functional recovery, and improvement in long-term prognosis, and how does revascularization link these three pieces together. So when I think about this and I look at the literature, there are some areas of uncertainty in patients with ischemic cardiomyopathy and severe multivessel disease. Which patients should undergo revascularization? Which approach of revascularization should be undertaken? And should viability testing be performed on everybody? And if so, which testing modality should be used? And what is the mechanism of benefit post-revascularization best explains improvement in LV function and in overall prognosis? The guidelines are very clear. These are the updated US and European guidelines in 2021. The US guidelines clearly state that patients with stable ischemic heart disease, multivessel coronary disease appropriate for CABG, and LV dysfunction, CABG is recommended to improve survival with a level of evidence level of evidence 1, and the guidelines are completely silent on the role of PCI. The Europeans taken a different approach, and they recommended CABG as the first revascularization strategy in patients with multivessel disease and acceptable risk. Again, a level 1 recommendation. And in patients with multivessel disease, PCI should be considered based on heart team evaluation of coronary anatomy, expected completeness of revascularization, and other comorbidities, including the presence or absence of diabetes. And they give this a level, a 2A type of recommendation. Where are the data? This is data from the STITCH extension study that Dr. Kremer has touched upon, of more than 1,200 patients, predominantly men. All of them had CAD amenable to CABG, and I want to emphasize that to enter into STITCH, you need to have amenable and a suitable anatomy prior to randomization, and the follow-up and the extension study was closer to 10 years, and there is clear benefit in all-cause mortality with 16% reduction in all-cause death, 21% reduction in CV death, and there were also benefits seen in other secondary endpoints. So, this is for CABG, but we know that not every patient has acceptable risk to undergo CABG. Not every patient wants to undergo CABG if you ask them. And CABG in the setting of acute of LV dysfunction carries a substantial perioperative risk, as also has been discussed. So this is why the long-awaited revived study was recently published, looking at the role of PCI in patients with ischemic cardiomyopathy. This is a UK-based study, substantially smaller, 700 patients. Again, male predominance, but the patients who are slightly older, all of them had to have severe CAD, and all of them had to have evidence of viability prior to randomization. The follow-up is also shorter. Note that there was absolutely no difference in the primary endpoint of the study, which is all-cause mortality or heart failure hospitalization, between patients randomized to optimal medical therapy alone versus optimal medical therapy plus PCI. And these are not, these are sick patients by different criteria. 60% had proximal LAD involvement, multi-vessel disease, 3-vessel disease was found in about 40%, and they all had low ejection fraction by definition. Note that 2/3 of these patients did not have angina at the time of enrollment, but this is a heart failure study where you want to enroll patients who have heart failure symptoms. Complete revascularization was achieved in about 71% of these patients, but there was no difference in outcomes, whether there was a significant improvement in whether revascularization was complete or near complete compared to optimal medical therapy. There was no difference in ejection fraction either. Baseline ejection fraction was 32%, and at 6 and 12 months, there was a non-significant increase in LVEF in both arms, and the difference between arms was also non-significant. There was, however, a significant improvement early on in quality of life seen with PCI, with almost a 12 to 13 point improvement in the KCCQ health status questionnaire, and this is considered a moderate benefit compared to optimal medical therapy. However, the difference between the two arms diminished as we approached the 12 and 24 months. Again, so ideally, I want to send everybody to revascularization, but the idea of the success of revascularization depends on actually restoring, achieving successful revascularization. The procedure depends on properly restoring blood supply. Angiographically, things may look appropriate. Intraoperatively, things may look good, but it all depends on what happens on the cellular level. Besides, these are invasive procedures that do carry some risk. This is data from Stitch showing that there was a 3-fold risk of 30-day death in the CABG arm compared to optimal medical therapy, and this is a peri-procedural MI, where there were 14 MIs in the PCI arm of Revived compared to none, obviously, in the optimal medical therapy. So, as you are trying to restore blood supply, as you're trying to restore coronary blood flow, you may run the risk of causing complications. This also needs to be taken into consideration. So here comes the idea of using viability to identify viability testing to identify patients likely to benefit from revascularization. And this is a very broad term, testing for viability. There are different modalities, as we have seen very skillfully by the previous speakers, and each of them depends on assessing specific aspects of viable myocardium. And in each has been studied independently and have been linked to a surrogate for improvement, which is improvement in LVEF. So to say that I will use viability to select patients is a broad term and needs to be to become more specific. The data that supports this is old and observational, as also has been shown, where there is about an 80% reduction in annual death rate in patients who were sent for revascularization in the presence of viable myocardium, whereas mortality rates were not different in the presence of non-viable myocardium. Some investigators, including Dr. Hakamovich and the group from Cleveland Clinic, have taken a more advanced approach, and they looked at the interaction between the percentage of hibernating myocardium with PET-FDG in relation to the rest of the myocardium, and they found that at around 10%, hibernating myocardium, patients start to derive more benefit from early revascularization compared to medical therapy, whereas if the burden is less than that, the benefits may not be realized. No discussion of this topic is complete without bringing up the viability subset of Stitch. I just want to mention one quick point about this, that this was a non-randomized allocation. Viability was not mandated. 50% of patients underwent viability, and almost 80% of them had evidence of extensive viable myocardium. And as you see at the bottom of this diagram, looking at the interaction between the presence and absence of viable myocardium on the benefit from revascularization, the number of patients without viability was very small, and the confidence interval crosses 1, and there is a possibility that and in a larger study, these patients may end up on the other side of the unity line, and then and this would change the conclusion based on this analysis. So what are the challenges with the viability testing paradigm that we use currently? As I said, it's a broad term using different modalities, different expertise, and different confidence and interpretation. And each modality in the best hands has different sensitivity and specificity, as Dr. Kremer pointed out. We think that things at the level of the myocardium are binary, and that there is either hibernating myocardium or infarcting myocardium, but I submit that these abnormalities coexist, and it is more of a continuum. Now, the most important thing, or one of the most important things in my mind, is the concordance between presence of evidence for hibernation and ability to successfully achieve coronary vascularization. So if you have a viable LAD territory, but the vessel is of poor quality, the flow and the Lehman to LAD is not optimal, or if you develop a complication, that is not a failure of the viability testing paradigm or cabbage. That was just a problem with not achieving coronary vascularization in that territory. And obviously, we cannot recommend routine viability testing in the absence of definitive supportive data. So as I conclude and just put things into context, the combination of myocardial ischemia and LV systolic dysfunction is a bad combination, and one that portends poor long-term survival. So if the patient has an acceptable risk and has acceptable anatomy amenable to cabbage, cabbage is the first choice in these patients. What do you do with patients who do not fit into that clear paradigm? I think there is room for individualized decision, and here comes the role of viability testing to further risk stratify and triage these patients appropriately at this step. The current paradigm, where we report viable versus non-viable, I think lacks the resolution needed to guide these decisions, and these decisions are nuanced and need to be taken to the next level. There is need for strategy randomized trials, similar to what was done in part 2, but need to be pragmatic in a sense, but also need to mandate adherence to findings or recommendations from imaging. And there is role also with the availability of artificial intelligence and machine learning, novel ways of looking at the myocardium and the availability of huge radiomics data to be able to better identify myocardial segments, and then take that to the patient level and properly identify patients more likely to benefit from revascularization. That was my attempt to put this topic together in 15 minutes. I thank you for your attention, and we'll move on to the next section of this webinar. So let me welcome my panelists. We have a versatile panel of physicians. All of them are astute clinicians, take excellent care of their patients. We have imagers. We have Dr. Safa Al-Muhdar, who's a multimodality imager. will be joining us. We have Dr. Ronnie Shantoof, she's from Zayed Military Hospital. We have Dr. Hussein Hishmat from Dubai, a skilled interventionalist. And we also have Dr. Ronnie Shantoof from Cleveland Clinic, Abu Dhabi, who's also an interventional cardiologist. So the way we will run this, I will ask Dr. Paul to present a case, and then maybe we'll take a few seconds to weigh in on the imaging and the clinical decision making. Then the other presenters will present their cases and we'll go from there.
Excellent, thank you, and thank you for a great overview. And again, I think one of the themes that has come out is that guideline-directed medical therapy is highly effective, and there's not a one-size-fits-all approach for these patients. And it really depends a lot, as we mentioned, is what the coronary anatomy looks like, the age and comorbidities of the patients to make an individualized decision. What I'd like to do in the next few minutes or so is just show, I have 3 cases just to kind of highlight how we use PET imaging for some of these difficult decisions. So I'll start there with the first case is a 61-year-old gentleman who's got a known history of an occluded proximal LAD and severe left ventricular systolic dysfunction. He is symptomatic with heart failure, and he's had a prior failed PCI attempt. And he was referred to us to be considered for high-risk PCI to the LAD. And here is his rest FDG images. So rest on the top, FDG on the bottom, short axis, horizontal long axis, and vertical long axis slices. I don't know if anyone from the panel, I don't know how much nuclear cardiology you guys are practicing, but if anyone wants to comment on these images.
I may comment. I think when we look at the wrist images and the FDG images and the short axis, we can see a matched in the anterior wall. There is a defect in the resting images with mismatched in the short axis. However, in the lateral walls, I think there is a mismatch indicating
Seems we lost Dr. Safar.
I agree with the with the comments so far. And what I'd say is, when I'm, this is a very abnormal study, and when I'm working with the fellows, it's always, to describe the severity and extent of the defect. And I think, as was highlighted, there's really absent perfusion here in the apex, extending into the anterior wall and also kind of into the apical to mid inferior segments, as well as absent severe perfusion defect here in the septum. Now, when we look at the FDG, we're really most interested in looking at the FDG signal where the resting perfusion is abnormal. So that's sort of what I talked about at the outset, is if the perfusion is normal, the myocardium is viable. And there can be some non-specific FDG uptake in myocardium that's being perfused. So I think we're most interested in where there's the perfusion defect. And as was noted, there's a large matched defect in the apex, anterior wall, and anteroseptum, which is shown here with the yellow arrow. So this would be a large fixed defect in an LAD distribution. The other thing I would draw your attention to, shown here with on the red arrows, is this area that's very photopenic. This is something we don't see all that often, but you can see there's some background signal here in the blood pool, but there's really no counts at all in this area here, sort of tracking along the anterior wall and apex. And here's the gated data, which shows severe left ventricular systolic dysfunction. And again, you see this really no counts here at that photopenic area in the LAD distribution. And when you correlate that with the echocardiogram, what you see here is a large LV thrombus. And that's why we saw some signal in the blood pool of the radiotracer, but the clot itself doesn't take up any tracers. So this was, severe LV systolic dysfunction with a large LV thrombus.
Paul, can we ask, can we ask, we have two interventional cardiologists, if this patient is in your holding, CV holding in the morning, and how would you, or in your clinic, let's make it more fair, how would you counsel these patients? He's been referred to you for CTO PCI, given the totality of information.
I wouldn't do it. I would like to see the anatomy first. But we know that failed trial of previous CTO PCI adds extra point to the score, so we know it's going to be difficult. And when I see a large mural thrombus, then I'm almost sure that this area is gone. And so definitely the risk is not justified.
Yeah, I would agree. I mean, I think, CTO PCI.
You're muted, Ronnie.
You should not be muted. Hello, can you hear me?
Yeah, we can hear you.
So CTO PCI is a very nuanced type of intervention where, I think it really comes down, and it's a very selective patients where it would make sense to consider CTO PCI, and it's really a shared decision making at that point with the patient. This is a patient with a large scar, highly reduced ejection fraction. You have to ask yourself, what are you doing it for, and why are you putting the patient at that higher elevated risk? Seeing the anatomy would, of course, I think, sort of put it together, but even without seeing the anatomy, the overall sort of gut feeling is that it's not going to make sense to even attempt such a PCI.
Excellent. Yeah, and I think that was the assessment in this case, and was not offered a repeat attempt at revascularization, and was referred to heart failure for advanced heart failure management.
Paul, can I ask you a technical question before you delve
Sure.
into your second case?
Yeah.
The FDG patterns vary. Sometimes you see complete uptake. Sometimes you see uptake only in the defect area. What is the explanation and the relevance of these findings?
So what I would say is, from the interpretation perspective, as I noted, you just focus on the area that doesn't have normal perfusion and see what the FDG is doing. From the technical side, there can be sort of heterogeneity in terms of the myocytes utilizing free fatty acids versus glucose. So you can have normal myocardium that has normal perfusion, and even though you've prepped the patient with fasting and then glucose and insulin to try and shift the cells to using glucose as a substrate as much as possible, some of that myocardium, normal myocardium, may still be using free fatty acids and not light up. The other technical point is that this is all relative perfusion, so everything gets scaled down from where the counts are the highest. And it's going to be that ischemic or hibernating myocardium that is most intense with FDG uptake. So even if some of the other myocardium that's normal is using glucose, it may just be using much less, and so you don't really pick up that signal because it's been scaled down. So the next case, this is a 68-year-old with a history of known 3-vessel coronary artery disease and ischemic cardiomyopathy with an EF of 35% on echo. Again, we start with the cath in these patients, and there's a known occlusion of the LAD, 60% RCA disease, and proximal left circumflex lesion as well, and was referred for rest stress viability PET to help inform the management. So what we have here is this is stress on the top, rest in the middle, and then FDG, short axis, vertical long axis, and horizontal long axis. Any thoughts about these images?
Dr. Safad, do you want to take another stab? I know we lost you on the first case, but Dr. Paul Kremer agreed with your interpretation.
And you're still muted.
Sorry. So looking at the top images in the short axis, we can see that in the anterior walls of there is almost matched defect between rest and stress. However, there is improved intake with FDG, indicating a mismatch that it goes also with the septum as well as the anterior wall, indicating a viable territory of the LAD.
Yeah, I agree with that. So there's a relatively matched defect here in the apex, as you noted, with increased FDG. And then I think it's a little bit more subtle, but in the inferolateral wall here, I think on stress compared to rest, there's decreased counts. And this is sort of what I was talking about before in terms of what we call ischemic memory. So some of the ischemic myocardium is often most intense with FDG. And so I think we sort of see that corresponding here in the inferolateral wall as well. Here's the gated data, which shows that decreased brightening of the apex there. And then here are the polar maps, which you can see this fixed apical defect with uptake on FDG and some inferolateral ischemia that is also intense on FDG. So based upon these findings, the patient underwent CABG and then had an echo at follow-up with a slight improvement in the left ventricular systolic function. So I think maybe in the interest of time, I'll stop there and we can shift for us, if that's okay, to the other case discussions. Or
great. Yeah, I agree. Thank you so much. Maybe Dr. Next is Dr. Ronnie. Yeah, Dr. Ronnie Shantoof is my colleague in Cleveland Clinic, Abu Dhabi. He's an interventional cardiologist and a preventive cardiologist at heart. He is going to share with us a case that he was involved with and involved decision-making. Ronnie?
All right, let me, it's not allowing me to share the screen.
Well, do you want to stop sharing? So, yeah.
There we go. All righty. Okay. You're able to see the screen? The PowerPoint?
You're good, Ronnie.
Good, okay. Great, so I have no disclosures. This is gonna be a case that we were all sort of all involved in, given our approach of MDT at Cleveland Clinic, Abu Dhabi. So this is a 46-year-old male patient, history of dyslipidemia. He actually presented to an outside facility with chest pain and a transient ST elevations that was reported for 15 minutes. Cath at the outside hospital showed multi-vessel coronary artery disease with the culprit being the LAD. The patient was treated medically for acute coronary syndrome at the outside facility, and at that point was subsequently transferred for evaluation of CABG versus multi-vessel PCI evaluation, essentially for CABG evaluation with 3-vessel disease and reduced ejection fraction. This was his ECG, and just draw attention to the fact that he has Q waves in the inferior leads 3 and ABF, and throughout a significant portion of his precordial leads. If it's a V3 to V5, I guess you can make an argument for a little baby little R wave there in V2. Echocardiogram showing the multiple views, and I'm not the imager of the group, but maybe at this point, maybe we can open up for a little bit of questioning in regards to what's everyone's thoughts in regards to the EF, and if we're going to be using this. And so I bring this case up as a question of, a lot of times decision making is done with just an echocardiogram and ECG, and we don't go on to sort of evaluate viability. And the other big portion is, how do we assess viability in the setting of acute coronary syndrome? And the third aspect is, what trial do we even use to apply to these patients? Because a lot of the trials, such as Stitch, and even the Revive trial, were not ACS trials. These patients were excluded from the patient data set. So this is a patient with a reduced ejection fraction that was in the 30-35% range, or 35%, slightly plus or minus. You can see anterior wall hypokinesis. You do see some inferior lateral wall hypokinesis, and you see the apex is essentially akinetic in the views hopefully they're coming through, and you have an LV thrombus there. I'll open it up. Any thoughts from the imaging standpoint from any of the folks on the call? Let
me ask Paul, Dr. Kremer, and Dr. Al-Mahdar, other than assessing the size of the infarct in the setting of acute MI, what is the role of viability testing acutely in ACS setting in the context that we are discussing in this session?
Yeah, so I think as was said, it's a bit of a leading or rhetorical question, in that I don't think there really is a role, which I think is what you were kind of getting to, at least clinically. I think there may be some research studies where looking at size of infarct and things like that can have prognostic value and things like that. But in terms of day-to-day clinical decision-making, I don't think the viability assessment comes into play in the setting of an acute coronary syndrome. I think as it specifically relates to using PET, it can be problematic, because after an infarct, if the myocardium is inflamed, it may take up FDG. So we typically don't do FDG imaging after an acute infarct, because the pattern can be non-specific in terms of the changes in myocardial metabolism that are happening within the first couple to few weeks of the infarct. And what I'd say in terms of the echocardiogram, and something that's worth emphasizing, is that we really use viability testing when the wall thickness on the echo is thinned out and akinetic, right? And so here, yeah, there's a thrombus, there may be some thinned out akinesis involving the apex, but I would argue that a lot of the LAD distribution in terms of that anterior septum is normal wall thickness and contracting, and hence viable. The other thing that I always keep in mind when I'm seeing these patients come into our CCU, as just a practical clinical point, is this LV looks, at least to me, a bit dilated. So, as there's Q waves on the ECG, there's probably a little bit of chronicity to this cardiomyopathy presentation as well. Whereas, oftentimes an acute infarct comes in a non-dilated LV, the EF may only be 45%, but the patient's in cardiogenic shock. So I think, keeping in mind, that echo also gives you some insight in terms of what kind of remodeling has happened already before the patient has come to see you.
Great. Excellent. So just bringing up at the bottom, do we have enough to say that it is viable? And it's perfect, kind of went right into a discussion in regards to how do we handle this in the ACS setting. So just taking a look at the coronary anatomy, this is a patient that had multivessel disease, overall focal lesions with a, probably a syntax score would be calculated at moderate. With the culprit, you can see sort of thrombotic lesion in the mid segment there, the LAD. see. So in summary, we had a 46-year-old. So that there's one thing, there's a young male patient that's a non-diabetic with an EF in the mid-30s. He's an ACS patient. ECG showing the Q waves, echo as we mentioned. We sort of had a discussion in regards to the viability, 3-vessel disease without left main with an intermediate syntax score. He did overall have Q waves. He did have somewhat of a small LAD target in the recent MI and ischemia with the LV thrombus. And so, I think one of the questions that comes up is, do we take medical therapy versus revascularization? Viability and the accuracy in the setting of ACS, which we did discuss, and do we take a cabbage versus a multi-vessel PCI approach? And I think this is a good moment maybe to stop before we kind of continue with what we did in this particular case.
Sure. Dr. Safa, if this is a patient you're seeing in your practice or during rounds, I mean, we kind of touched already on the viability question. What would your management approach be?
I mean, we can take into consideration this patient is young. He's 46 years of age. That is something that we should really take into consideration. The setting of developing a thrombus and thin wall, are these echo done within, what's the frame window of these echo images within the acute setting? Because it looks like it is sort of a subacute images, if I'm correct.
These were, well, it's hard to, I mean, the patient's symptoms were within 2 to 3 days of transfer, and the echo would have been upon arrival. So probably, a few days after the event itself. Now, the patient's backstory, whether or not they had, prior symptoms to presentation, is always very possible, because a lot of patients, especially in our population, do present late and sort of, sit with lingering pain before it gets severe, before presenting to the actual, hospital.
I think from my perspective, I would go with revascularization, either depending on the anatomy. I missed actually the angiogram, either with the multivessel stenting or cabbage. I think we should take all the consideration and revascularize this young gentleman.
Hussein, any thoughts on multivessel PCI versus cabbage?
Well, this will be left to the heart team discussion and the logistics of the system. Looking at his angiogram, his LAD will need a stent, circumflex will need like 2 long stents, the RCA would need 2 long stents also. And I missed whether he's diabetic or not. I missed that. So it all depends on the heart team discussion and the logistics. Both options are viable in my opinion.
So, that's great. So I think one of the extra questions that does come up is whether or not we can achieve complete revascularization with either modalities. And I think this is a critical aspect, and there's data that's sort of mounting in regards to this support that if we were to take one approach versus the other, in general, cabbage can, is a greater likelihood of achieving complete revascularization compared to PCI. In this particular case, given the recent MI, which doesn't necessarily not make them a cabbage candidate, but the anterior Q waves, this relatively small LAD target, not that that's prohibitive, but the LV thrombus, I think, in the end, sort of pushed us in regards from a heart team approach to take. And then I would add that we can actually achieve complete revascularization with PCI, that we did go ahead with that approach in this particular case. So he underwent complete revascularization, as our colleague noted, multiple stents, of course, a lot of layers of metal, and of course this does open up for chance of restenosis in the future. But so PCI overall was successful. So I don't want to, just for the time, so we can move on to the next case, but I think we always got to look at our patient and kind of think about our data. Most of the time in the real world, we do operate in the gray zone and maybe sort of dabble into the green. And, when we're lucky, we get a patient that's, very clearly in the green or the red, and that sort of makes it easier for us when we have large randomized controlled trials and large data sets. And so, I think the two big questions were, could this patient have gotten immediate culprit primary PCI and then staged the others later, versus the subsequent decision-making that we did do in this particular case. And then we'll stop here. I do have other slides, but for the sake of the time, I think we do have to ask ourselves, what trial makes the most sense in this particular case? This patient would not fall under 6 because this is not a stable patient. Syntax score they wouldn't fall under because there was very few patients that actually enrolled low ejection fraction. Ischemia trial is actually interesting in that there was a reasonable subset of patients that did have, or there was a small subset of patients that did have an ejection fraction that was above 35%, but still below 45%, which was looked at, and there was benefit in regards to that group for revascularization. And then you have the complete trial and the revived BCIS-2 trial, which was recently discussed, which again, the patient would have fallen out of because patients with an MI within the last 4 weeks were excluded. So I actually think this patient falls under the complete trial, which would have been for complete revascularization in somebody that presented with an ACS picture that was STEMI. This patient did have transient ST elevations without primary PCI, so it's a little hard, but again, we're trying to take these patients and place them in the right trial. And then just the last thing to bring up is, when we look at a lot of these trials, the average age are anywhere between 60 and 70, a lot of these data sets. And when we see these patients that are in their 40s, it becomes really hard, and we have to keep that in mind, because mortality in general for these patients with low EF are, of course, anywhere between 40 and 60%, depending on what trial we're talking about. And so we're trying to take a 40-year-old and already they have a dismal outcome and trying to figure out what to do. So I think with that, I'll stop there and hand it back to the moderators.
Thanks so much, Ronnie. I just want to answer, there was a question that came in the chat. You kind of answered this by inciting the complete trial. So the audience, the individual in the audience said, a multivessel disease with the LVEF less than 40% and suitable anatomy, CABG has an edge, especially can completely revascularize. So in the setting of an acute MI, especially ST elevation, you would want to try percutaneous.
Yeah, well, so actually, so the complete trial, which was patients presenting with a STEMI and then went on to get a revascularization of non-culprit lesions, actually about 700 patients within that trial actually had a reduced ejection fraction. That's actually more patients than are many of the CABG trials, if you think about that. So whether it's the CAST trial, the VA study, even the Revive trial, which had around 700 plus patients. So you actually have even though it's a subgroup analysis, it was a pre-specified subgroup analysis, it is still a large patient population, which did show a benefit in that particular subgroup, significant benefit. So while I think CABG in totality still makes the most sense when you're selecting patients, I think when we're dealing with in ACS, we don't have that same trial data to really reflect that. I think stable patients is a little bit more clear. We have multiple trials sort of reflecting that, but really the unstable ACS population is still, I think we're really in the gray zone at best.
Fantastic. Dr. Hussain, do you want to, thank you so much, Ronnie, for your presentation. And I'll turn it over to Dr. Hussain to present the third case of the moderated case discussion section. And as he brings up his slides, Dr. Safa, you have access to PET and CMR and everything. How do you decide when to go PET, when to go CMR? Are any guides, any ideas?
Actually, we don't have access to PET in my institution, so I send some of them to you. But we have actually CMR definitely. We use CMR has been discussed by our colleagues. CMR can provide you a lot of information starting from the cine images with the different regional wall motion abnormalities using dobutamine as a stress modality, as well as low dose dobutamine. looking for viability. But the main thing that is being used in CMR is the late gadolinium enhancement, in which that you are looking for a specific distribution of the late gadolinium, and mainly in the subendocardial region. And the degree of and the thickness of the late gadolinium dictate if this part of the myocardium is viable or not. And 50% thickness or more would give you the information that this part of the myocardium is not viable. So you will not really go ahead and revascularize it. There is also a lot of new modalities in CMR using mapping techniques and that will detect viability of the segment that you are looking for.
Fantastic. Thank you so much. Dr. Hussein?
Thank you, Dr. Firas, for the kind invitation. I'm glad to be with you and with this eminent group of cardiologists of different backgrounds. The case that I'll be presenting is it shows you the two ends of heart failure: the acute with cardiogenic shock and the chronic with severe LV dysfunction in the same patient. So this is a situation that I came across 10 months ago. It's a 64-year-old gentleman who was referred to us from an outside hospital because he presented with an inferior ST elevation myocardial infarction. He was thrombolized and then he was shocked. And looking back into his past history, he sustained a myocardial infarction 11 years ago. And he refused to do anything. He refused to do angiography. He's not hypertensive. And to make it worse, he decided that he's doing fine, and therefore he stopped all his medications, aspirin and statins, 1 year earlier. And so that's the ECG that I received. There is evidence of pathological Q waves in the inferior leads, probable biatrial enlargement, and of course the stigma of the pathological Q waves also in the anterior leads. And this can explain why is he shocked. He probably occluded a vessel 10 years ago, then he got another large vessel occlusion in the night. It took us 5 hours until he reached us. He arrived to us on dopamine with systolic blood pressure of 2 digits. So we started norepinephrine. He was in close to developing pulmonary edema in addition to the low blood pressure. His examination showed that apex is heaving, and I tend to regain my clinical skills. When I see a heaving apex, I think that that process is chronic. And echo actually suggested that even further, because the ventricle was dilated with a dyskinetic thinned apex and anterior wall, ejection fraction 25%. The inferior wall is hypokinetic, the left atrium is dilated. We look at the RV when the patient is shocked. Apparently the TAPSE was okay, so RV functions were fine. And of course, we had to take him to the cath lab because of the shock state. And in patients with shock, I'd like to take a right heart cath to understand the wedge pressure and to understand the RV function. We use the pulmonary artery pressure index, the PAPI. And in this particular patient, we were lucky that his RV functions were fine, and therefore an LV support device was sufficient. Looking at the angiogram, the ramus, the circumflex, and the diagonal branches were okay. There is an occlusion, total occlusion of the proximal LAD with a very ambiguous cap with branches coming at the stump of the occlusion. And we see that the mid and distal portions of the LAD are filling via collaterals from the left coronary. So we thought that this LAD is the one that he sustained the infarction 10 years earlier. The right coronary was clearly the culprit, the appearance of the lesion with a probable small thrombus at the end of the lesion. So that was the situation, a critical RCA lesion and a total occlusion of the proximal LAD in someone who's shocked with systolic blood pressure of 90 on 2 vasopressors. The culprit, of course, was the RCA, and that was our plan to tackle. Then we thought that let's think of the LAD sometimes later on. So we had the Impella CP. We deployed it across the aortic valve, and it was helpful because while we were trying to cross the RCA, we got an abrupt occlusion, and that's the moment where you need a mechanical circulatory support device to back you up. Eventually, we crossed with a better wire, and we dilated, and that's the final result after 2 stents in the RCA. And we were lucky that after the angioplasty, his blood pressure reached 3 digits with no chest pain. He was comfortable, and so we were encouraged to wean the Impella and remove it in the cath lab. We like to do a dry closure because these patients are on aspirin, ticagrelor, and they were just given thrombolytic therapy. So we need to make sure that the puncture is clean and dry. So we inflate a balloon and we pull the ProGlide sutures, and we make sure with injecting through the lumen of the balloon that the puncture site is fine. And we were so glad that his blood pressure recovered, and he was able to be ambulated 2 days after the procedure, and he was discharged walking on aspirin, ticagrelor, perindopril, bisoprolol, high-intensity statin, and spironolactone because of his poor ejection fraction. Then we saw him 1 month later on. The patient was compliant to medications. There's no angina. He was clinically euvolemic. His blood pressure was okay. The heart rate was fine. And then we had to discuss with the patient the options for managing the other occlusion. We tell the patient that you had 2 vessel disease. We fixed 1, so it still remains in their mind that we only partially treated them, and he needs to be treated better. So I agreed with him that fixing the LAD wouldn't be as easy as the RCA, as if the RCA was easy. So we said, let's do something to understand what are the prospects of engaging into this CTO. So of course we have experts in imaging, so if I may leave them the floor to read the images, because I'm not that experienced in reading these images. Maybe Dr. Kramer or Dr. Safa or Dr. Feroz.
Thank you, Dr. Hussein. It looks like this is a thallium study.
Yes.
So we haven't touched on thallium, but you look at thallium is a potassium channel analog that has the ability to redistribute. So again, as Dr. Kramer explained, you're looking for a resting perfusion abnormality, and you see on the short axis up top, you see there is a resting perfusion abnormality, extensive anterior, septal, and inferior, extending from the apex to the mid-ventricle. And on the 4-hour redistribution, you see it fills back up in the basal segments, but to a lesser extent as you move to the mid and apical segments. This is partial viability and probably lack of viability in the distal LAD territory. Safa or Paul, what do you guys think?
Yep, I agree with that interpretation.
Yeah.
Okay, so that was the report that shows that there's some viability. Well, the majority of the segments were non-viable. The apex, the apical 2/3 of the anterior wall, the apical half of the septum, apical 1/3 of the lateral wall, they were all non-viable, with viable myocardium in the basal 1/3 of the anterior wall, and some hibernation or stunning in the basal inferior wall. And I would like to correlate that with angiography, so let's look at the angiography again. The mid and distal parts of the LAD that are non-viable based on the thallium are filling, whereas the basal part, it's getting this septal perforator is not filling. So maybe we can discuss that. What would Dr. Ronnie do for this gentleman?
Yeah, so I think this is you know, we have some viability. I think when it comes to CTOs, it's really important to understand the patient's symptoms. You know, overall, multiple trials, I mean, most recent trials showing that despite revascularization, we did not see a change in ejection fraction, although there was no change in ejection fraction even with medical therapy in the REVIVE trial, which was a little bit surprising, I think, overall. I think to revascularize CTOs for LVEF alone, we don't have strong data for that. I think for symptoms, it's a reasonable if we feel that the risk benefits in favor for tackling a CTO. This is not necessarily a straightforward CTO. It is a long lesion. It is right at the bifurcation at the ostium. We do have multiple vessels coming off of that LAD. But so, you know, this one does require a sort of a really detailed conversation with the patient. You do have a ramus that you could put at risk. That's right there off of the LAD ostium. So look, I think if the patient's doing really well and they're not optimized on medical therapy, it's very reasonable to optimize them and then continue to reassess at that point. If they're completely optimized and are still symptomatic and they understand the elevated risk, it could be one that's worth you know, tackling.
Yeah, that's what we did exactly, Dr. Ronnie. We kept him on medical therapy, and we started the 4 pillars: Entresto, empagliflozin, carvedilol, spironolactone, in addition to dual antiplatelets. And during his last encounter with his treating doctor, I called the treating physician. He told me the patient is fine. He has no complaints, reasonable effort tolerance, with an ejection fraction of 30 to 35%. So these are the points to consider. In STEMI and cardiogenic shock, culprit-only revascularization is important. Trying to achieve complete revasc in the acute phase, of course, is associated with more renal failure and higher mortality. Support devices in cardiogenic shock there's no question about it. As for heart failure management, the benefit of CTO PCI is questionable. Viability testing, of course, can help and fine-tune this decision, and medical therapy remains the cornerstone. Thank you.
Thank you so much, Dr. Hussein. We're 4 minutes after 9. I want to be respectful of everybody's time. And I really want to thank all the speakers and the moderators for this session. Great discussion, great cases, great input from everyone. Thank you so much. This brings us to the end of the CME accredited part, and we look forward to seeing you again in the next session of multimodality rounds in November. Stay tuned. And now I will introduce Dr. Mohammed Al-Harari, who will be providing an update on treatment of heart failure as part of the non-CME accredited part of this session. Dr. Al-Harari.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for us, and it's a pleasure for me to be here and to take this slightly differently, because I'll be talking a slightly different topic. It's heart failure. I'd like to thank Novartis for asking me to do this presentation. So we'll just go ahead. So what I'll be talking about is really sort of updates on the management of the full spectrum of heart failure, the role of RNA, and what's new. So what I'll be talking about, I'll be talking about the new definition and classification of heart failure, evidence-based disease-modifying therapy for HFrEF, just run through them, use of sacubitril/valsartan for inpatients with HFrEF, including de novo use. I'll talk a little bit about the Bioneer Trial and its recent post hoc analysis. And I will just mention the new European Society of Cardiology and the American algorithm for HFrEF. Following that, I will talk about ARNI and HFpEF. Does it work and what is the evidence? Brief mentioning or talk about the Paramount, Paragon, and Parallax trials in this respect. And then we'll touch briefly on the new American guidelines algorithm for HFrEF and HFmEF. So for the definition of heart failure, as a lot of you know, that in March last year, the Heart Failure Society of America, the Heart Failure Association of the European Society of Cardiology, and the Japanese Heart Failure Society met together and proposed a new definition and classification of heart failure, as well as the updating the stage of heart failure. This has been adopted and incorporated in the new American guidelines for heart failure. Basically, as far as the definition remains that heart failure is a syndrome of symptoms and signs of heart failure associated with underlying structural or functional abnormality of the heart. But in addition to this definition, that you need to have one of two, either raised natriuretic peptide or objective evidence of pulmonary or systemic congestion. The classification of heart failure based on ejection fraction, as you know now, three classes, HFrEF, HFpEF, and HFmrEF, the 41 to 49%. But the new added class is the heart failure with improved ejection fraction. And this is for those who used to have ejection fraction less than 40%, but then improve, become like mildly reduced and the point of making this group separately, because to emphasize the importance of keeping this particular group on full guideline direct medical therapy, which is now a class 1 recommendation. Now, I remind you and myself that HFpEF is bad. It's as bad as HFrEF, and they both continue to have a high similar mortality. And the proportion of patients with HFpEF now is increasing, so the prevalence is increasing compared to the HFrEF, and that's I think largely because we are getting better at diagnosing it, and we're having more and more sort of good treatment for it. Now, for the HFrEF, we've been blessed with having a lot of trials that show really convincing benefit, morbidity and mortality. Starting with the ACE inhibitors in the 1980s, going to the ARBs, showing again benefit in patients who do not tolerate these inhibitors, the fantastic beta blocker trials, which now we've been established and we use, as well as the MRA trials. But despite all these, we continue to have high morbidity, high mortality, and there is always and has been and still probably unmet need. And in 2015, we have this new agent, the interested sacubitril falsartan, which is a dual-acting drug with two components: the falsartan, the ARB that inhibits the ARB angiotensin receptor antagonist, and as well as the sacubitril, which is the important bit that inhibits the neprilysin, which tends to damage our good BMB. So we save more of that. And as you all know, this has been studied in a landmark trial, which is the largest mortality and morbidity trial in patients with HFrEF, more than 8,000 patients, randomized to sacubitril falsartan versus enalapril with long follow-up. And the trial meets all primary and secondary endpoints with 20% reduction in combined primary endpoint of heart failure, hospitalization, and mortality. 40% reduction in heart failure hospitalization in the first 30 days, as early as 30 days, 20% reduction in sudden death. There's not an anti-arrhythmic medication, but 20% reduction in sudden death, 16% reduction in all-cause death, and in better protection for your kidneys, and much significant reduction in T-proBNP as a marker of reverse remodeling, as well as the improvement in the quality of life and very good tolerability. Then the question came, could it be used for inpatient safely and effectively? And can it help those who actually are not on ACE/ARB as the paradigm that, switching, but as de novo. And it has been looked into several trials, but particularly the one that we all know about is the Bioneer Trial, which randomized 881 patients with acute decompensated heart failure with reduced ejection fraction to sacubitril or valsartan, sacubitril valsartan or versus enalapril, and they looked into a short follow-up of 8 weeks only, and they just want to look at the effect on NT-proBNP as a marker for remodeling, safety, tolerability, and secondary as an outcome. And the study again meets its primary and secondary endpoints with significant reduction of NT-proBNP as well as reduction in cardiovascular death or heart failure rehospitalization, and with good tolerability similar to the paradigm. The benefit for those who actually on de novo, again, looked into more than one trial, but partly in this Bioneer trial as a subgroup analysis, because a third of the patient in the Bioneer actually new heart failure, completely new heart failure, and 50% actually were not on ACE or ARB. And what they found that this group, the de novo group, really got as much as benefit as those with the worsening heart failure from being on sacubitril valsartan versus enalapril, with reduction in cardiovascular death or hospitalization and reduction in NT-proBNP. Then, carrying on, we looked or been looked into the use of ARNI in post-MI, and this was studied in the Paradise MI trial, and which was presented in ACC last year. Now, this is a large trial, again, of more than 5,000 patients, a patient admitted with acute myocardial infarction and having either reduced ejection fraction and or pulmonary congestion. And the trial had a long follow-up of 23 months, and the primary endpoint was cardiovascular death or first heart failure hospitalization or development of heart failure as an outpatient. The trial did show a clear trend of benefit of being on sacubitril valsartan versus ramipril, but this did not reach statistical significance. But when they, again, this is a subgroup analysis or post hoc analysis, when they looked at not just the first event of heart failure, but all heart failure, total first and recurrent, then when they did that, they found actually that sacubitril valsartan did significantly reduce primary outcome. And the other thing, when looked at again in further post hoc analysis, is if they looked at all the event that reported by the primary by the investigator, and that basically so the investigator will report all endpoints, but will not be all taken because they don't completely meet the clinical event classification by the trialist. But if they added that again, they will. If they included all the investigator report event, again the trial will achieve statistical significance in favor of sacubitril valsartan. Now, furthermore, in August this year, just last month, there was again further analysis of the data of the Paradise MI using the win ratio analysis. Now, this win ratio analysis, you probably know, that's being used more and more, and we've seen it used in the Impulse trial and the Diamond trial, and they've used it now as post hoc analysis as in the Paradise MI trial. And basically, what they did in the win ratio analysis, what they do, they look at each patient in the treatment arm and compare that patient with every patient in the treatment arm and look at all the outcomes starting with the most serious, so the mortality, hospitalization, quality of life, etc., etc. And what they do when that particular person compared to each one of those others in the treatment, and if they find that he gets the benefit first compared to that other person in each of the three, or in each of the outcomes, then that will be a win for that group, and so on and so forth. It is so long protracted, and again in this analysis, they use the totality of event, or reported by primary physician and all that, and basically when they did that, basically they found that the sacubitril/valsartan wins against the ramipril with statistical significance. But again, this is a post-hoc analysis. But what you see that there are all hints that actually it probably is beneficial even in post-MI. Now we cannot just carry on with the HFrEF without mentioning what happened in the last few years with the SGLT2 inhibitors, with the use of empagliflozin and dapagliflozin in the large two landmark trials of DABA heart failure and EMBRA reduced, both in diabetic and non-diabetic HFrEF patients. Both studies were positive, meeting all the primary and secondary endpoints for reduction of cardiovascular death and heart failure hospitalization. And basically, with all this information coming on, the guidelines of heart failure has to be updated from the 2017-2016 guidelines, and we'll just I will go through the new algorithm for HFrEF, both in the European Society of Cardiology focus last year, which now basically emphasized the importance of going away from the step-wise approach in treating HFrEF to starting all the four pillars, the ASR, beta blockers, MRA, and SGLT2 inhibitor, as soon as it is safe to do so, rather than wait for weeks and weeks and months. And that's also been highlighted in the new American guidelines of May of this year, putting step 1 as starting the RNA, ACE, beta blockers, MRAs, and SGLT2 inhibitors as step 1. And the American went a step further by saying that now RNA should be used instead of ACE inhibitors, and the ACE inhibitors should be used only if the use of RNA is not feasible. And the guidelines now say that it is class 1 recommendation to start guideline-directed chemotherapy during hospitalization as soon as the patient is stabilized. Okay, moving on to the HFpEF. HFpEF, as you know, unfortunately, there were not many trials that showed any significant mortality and morbidity benefit throughout the last decade or more. And the question was, and maybe becoming clearer now, could we use similar, even the same medication that we use for HFrEF for HFpEF? Unfortunately, ACE inhibitors fail to give us any added benefit to patients with HFpEF. And the ARB, particularly in the CHARM Preserve trial, which again, large trial of more than 3,000 patients, comparing candesartan versus placebo in HFpEF patient, and probably HFmef as well, which is much more than 40%. Again, just falls short of meeting its primary endpoint of reduction of cardiovascular death or heart failure hospitalization, but it did significantly reduce heart failure hospitalization, and is now has been class 2B recommendation for HFpEF patients. Similar thing was the TOPCAT trial for the use of MRA in HFpEF patients. Again, failed to achieve its primary endpoint of cardiovascular death, heart failure hospitalization, or resuscitation, but did reduce heart failure hospitalization. It has been class 2B treatment. So what did the previous or old guidelines say about HFpEF management? In the 2017 guidelines, really there was emphasis more about treating morbidity, diuretic, revascularization, treating hypertension, and given ARB and MRA's class 2B recommendation. In the last European Society of Cardiology guidelines of August last year, it was talking about HFmef, and gave class 2B recommendation to all the four pillars. However, there was no added recommendation for the HFpEF in that guideline, in those guidelines. the question really, as far as our talk tonight, or part with the emphasis on the ARNI, does ARNI have a role in HFpEF patient? And if so, what's the evidence? I'll be touching on 3 trials, the Paramount, Paragon, and Parallax. The Paramount was probably the first one, and this is as a small trial of 300 patients, which showed follow-up 12 weeks, comparing sacubitril valsartan versus valsartan in HFpEF patient, and they looked at the evidence or the effect on the NT-proBNP, as well as the echocardiographic measure of diastolic function, the LA size, the LV size, quality of life, and NYHA class. And the study did meet all its primary endpoints, with a significant reduction in NT-proBNP with sacubitril valsartan, reduction in left atrial size, and improvement in NYHA class. This was followed on by the large, well-known probably, the Paragon heart failure trial. And this is a large study of nearly 5,000 patients, compared sacubitril valsartan versus valsartan in HF patient ejection fraction more than 50%, 45% ambulatory patients with a long follow-up. The trial did show that sacubitril valsartan does reduce the primary endpoint of cardiovascular death and or heart failure hospitalization by 13%, but unfortunately this did not reach statistical significance. However, the trial, if they added on urgent heart failure visits to the primary endpoint, the study would have been statistically significant. And we have to remember that the study of sacubitril valsartan was actually against active comparator, not against placebo. And we'll come to that maybe later on. And the effect of benefit was predominantly because due to reduction of heart failure hospitalization. The study, however, they all met all its secondary endpoint, with reduction of the improvement in the NYHA class, improvement in quality of life, and kidney protection. And furthermore, when they looked at subgroup analysis of patients, they found that patients with ejection fraction up to 57% will gain a benefit from being on sacubitril valsartan. Furthermore, when they looked at the females, which contribute more than 50% of the patients, that all the female, regardless of the ejection fraction, do significantly benefit from being on sacubitril valsartan versus valsartan. And look at this graph, you find the females in the red colored graph or line on sacubitril valsartan significantly benefit, do better than the females who are not sacubitril valsartan, and better than males, regardless whether being on sacubitril valsartan or not. Moving on to the Parallax trial. The Parallax trial was a large trial of 2,572 patients, and it was actually a 3-arm trial of patients with HFrEF and HFmEF. And the first arms compare sacubitril valsartan versus enalapril. The second arm, sacubitril valsartan versus valsartan. The third arm, sacubitril valsartan versus placebo, and with 24 weeks follow-up. The study did not look at outcome, but looked predominantly at the effect on NT-proBNP and 6 minutes walk and quality of life. The effect of NT-proBNP was significant, reduction of NT-proBNP with sacubitril valsartan versus all the other modality of treatment, including placebo, but there was no significant difference in the quality of life from NYHA class in this study. However, this study had a post-hoc analysis just being presented in last month in the European Society of Cardiology, and when they looked at the heart failure hospitalization and in this study, and what they found that the group on the sacubitril valsartan significantly have significant reduction in heart failure hospitalization, regardless whether they are being on the ACE or the ARB or placebo. And when they looked at each group separately, they found sacubitril valsartan did much better in reducing heart failure hospitalization. And the benefit, the effect on heart failure hospitalization did correlate with the reduction of the NT-proBNP. So that's the Parallax. I have to just go to 2 papers by John McMurray and his group, And the first one, what they did, they combined all the data of the Paradigm and Paragon, and basically what they want to look at the effect of sacubitril/valsartan versus obviously ACE in the case of Paradigm and ARB in the case of Paragon across all ejection fraction. And what they found that all outcomes were reduced significantly in patients receiving sacubitril/valsartan compared to RAS or ACE. And that's all outcomes, as you see on the right side. And what they found that the continuous benefit actually, the benefit actually continues throughout the ejection fraction, although it seems to tail off or less at the higher ejection fraction. But then the benefit actually in women persists even to higher ejection fraction. The other work that John McMurray did with his group is try to see the estimate of effect of sacubitril/valsartan had it been tested against placebo, not against active comparator. And how they did that, basically they looked at the whole data of Paradigm, as well as charm alternative and charm preservers, which to the two trials we used candesartan versus placebo and HFpEF and HFrEF. And basically what they found that when analyzing data from the Paradigm heart failure and the charm alternative, the estimated reduction of the primary endpoint by sacubitril/valsartan would have been 48% if it is against placebo. And when analyzing the Paragon heart failure and the charm preserved trial, the estimated reduction of with sacubitril/valsartan against placebo would have been 29%, but would have been statistically significant. And that would have been against the benefit will be seen in all the outcomes, as you see on those graphs. And as you probably know, that in February of last year, the FDA had, with those information, have granted expanded indication for the use of sacubitril/valsartan regardless of the ejection fraction or without characterizing by ejection fraction. And this label has been approved by UAE as well. Talking about HFpEF, we cannot just carry on without mentioning the SGLT2 inhibitors with the two landmark trials of the IMBRA preserve, again presented last year, using empagliflozin and HFpEF patient, or HFpEF and HFmEF, with a diabetic or non-diabetic with long follow-up, and again composite endpoint of heart failure, hospitalization, cardiovascular death, which was significantly reduced by 20% using empagliflozin versus placebo. And again in August of last month, the DELIVER trial was presented in the European Cardiology meeting using dapagliflozin in HFmEF and HFrEF patient. And this actually trial included also the heart failure with improved ejection fraction and comparing placebo, dapagliflozin against placebo in diabetic and non-diabetic. And again, the trial was positive, achieving all its primary and secondary endpoint with significant reduction of primary outcome of heart failure and cardiovascular death, heart failure hospitalization. So we said that the European Society of Cardiology guidelines for August last year did not mention anything new about the HFpEF, but the American guidelines did take all the information on board except the DELIVER trial, and their algorithm incorporated that. So for the HFpEF patient, SGLT2 inhibitors are class 2A, although I think after DELIVER it will probably be class 1, and the RNA class 2B. For the HFmEF, again, similar things, SGLT2 inhibitor class 2A, ASR, RNA are class 2B. In summary, ladies and gentlemen, sacubitril/valsartan is a unique dual blocker of renin-angiotensin system and neprilysin. And the HFrEF from the Paradigm trial is shown superior to ACE inhibitor with significant reduction of cardiovascular death, rehospitalization, sudden death, all-cause death, with improvement of quality of life and better safety and kidney protection. It is safe and effective when initiated during hospitalization and when initiated in patients without previous ACE or ARB, the de novo group. And as you know, RNA are now class 1 recommendation for HFrEF patient in the heart failure guidelines. The ARNI was the first drug approved by FDA across the whole range of ejection fraction. It's now class 2B recommendation for HFmef and HFbef and HFmref. It's approved in 115 countries worldwide, with more than 2.5 million patients a year exposed to it. And that's it. Thank you.